Hi, we are sharing a video after a long time with voiceover. This video is to demonstrate the dissection of retroperitoneal space on both the sides. This is on the left side. You can see we are opening the retroperitoneum by lifting the peritoneum in between the external iliac artery, the infundibulopelvic ligament, and the round ligament. So this is lateral to the infundibulopelvic ligament, also known as the oncological approach. When we go medial to the infundibulopelvic ligament, it is known as the endometriotic approach. Now, here you can see the dissection being made with the help of harmonic, which is sharp dissection and blunt dissection both. When sometimes this space is infiltrated by endometriosis, we have to resort to sharp dissection. You can now see once we are dissecting, it's all avascular plane and fibroareolar tissue. You can see the peristalsis of ureter on the right side of the screen. We are now dissecting medial to the obliterated umbilical artery, which is also the continuation of the internal iliac artery. And we are trying to locate where the uterine artery is. This space is known as lateral pararectal space, also known as Latsgow space. Only one structure crosses from the lateral to the medial side, which is the uterine artery, which is slowly coming into picture now. This uterine artery will then go further and move over the ureter. So the uterine artery goes above the ureter and the ureter goes below the uterine artery, the proverbial water under the bridge. And below the uterine artery, below the ureter, you would find the uterine vein. So you can see the tortuous uterine artery in front of you with the help of sharp and blunt dissection. Now we are dissecting the paravesical space, and if you keep on dissecting the paravesical space, and push everything towards the uterus, you will reach the pelvic floor, which is the levator ani muscle. The dissection which we have to do when we are doing a laparoscopic radical hysterectomy for malignancies. Here again, we are trying to separate the uterine artery from the vein below, and the uterine artery is then taken with the help of harmonic, or one may prefer bipolar. So this is a typical anatomy of the left-sided retroperitoneum. You can see the internal iliac artery, the first branch of internal iliac artery crossing the pararectal space, the uterine artery being taken, and the ureter. We are now again going on the right side in a similar fashion, where we are taking the round ligament and then going lateral to the infundibulopelvic ligament. The technique, as I already described, is the oncological approach. Now here, once we pull the peritoneum, you can see very nice champagne effect because of the CO2 which enters the retroperitoneum. And this dissection is not at all difficult. I think to study the anatomy during laparoscopy is very good, and then extrapolate it to our obstetric cases. Everybody should learn internal iliac artery ligation and stepwise devascularization, which is a life-saving procedure so many times. Here, the important thing is being lateral and parallel to the infundibulopelvic ligament. You can now see the impressions of the external iliac artery and external iliac vein. Again, you can see we are dissecting, sharp and blunt dissection together. Try and avoid any hemorrhage here because that would spoil the field. You can now see the uterine artery coming up. The ureter is below the forceps, which is in my left hand. So slowly and steadily we develop the iliac tree, and while developing the iliac tree, we remove the fibrofatty tissue over the vessels so that the vessels are nicely exposed, and it is easier then to take the uterine artery. Now, of course, we have to a little bit enlarge the incision so that the visibility is good. You can now see I am, going parallel to the obliterated umbilical artery, and once you are parallel to it and you dissect the tissues, you can very clearly see that. So you can now see the obliterated umbilical ligament or the continuation of the internal artery very nicely. So sharp and blunt dissection. Now the part where we are dissecting now is actually the paravesical space. The ureter is again below my left hand instrument, and you can very clearly see the uterine vessel now, which is traversing from the lateral to the medial side, and further it would go over the ureter and ureter would run below it. So now you can clearly see the origin of the uterine artery, which is then again taken here with the help of harmonic. But one may prefer a shearer or one may prefer a bipolar to take the uterine vessel. In this case, the uterine artery coagulation at origin was done so as to aid, help dissection and help achieving hemostasis. Thank you so much.